Hi, everyone. Good morning. My name is Nicole Parellada. I am one of the chief medical residents, and it's my pleasure to welcome you to Grand Rounds. Um, our first presenter is Dr. Rodolfo Galindo, who graduated from the Institute of Medical Sciences at the University of Havana in 2005. He completed his internal medicine residency and endocrinology fellowship at the Albert Einstein College of Medicine and North Shore University Hospital in New York. After completing fellowship, Dr. Galindo joined the Mount Sinai School of Medicine as assistant professor and director of the Inpatient Diabetes Service. In 2017, Dr. Galindo joined the faculty of Emory University to work with his mentor, Dr. Guillermo Umpierrez, on clinical investigation in diabetes and obesity. And currently, Dr. Galindo is an associate professor of medicine at the University of Miami and director of the Comprehensive Diabetes Center of UHealth, as well as the director of diabetes management for Jackson Health System here in Miami. His clinical research areas of interest include management of diabetes, obesity, and CKD using diabetes technology. His research program is supported by the NIH, the NIDDK foundations, and the industry. His works have been published in multiple high impact journals, and he served as a member and author of national and international diabetes guidelines, including the Consensus Statement on the Use of Diabetes Technology in the Hospital, the AACE Diabetes Mellitus Comprehensive Care Plan in 2002, and the AACE Algorithm for the Management of Type 2 Diabetes in 2003. He is currently a member of the task force to update the diabetes ketoacidosis guidelines and a member and writing author of the Standard of Care for Diabetes Guidelines from the ADA in 2024. Please help me to welcome Dr. Galindo to the Department of Medicine's Grand Rounds.
Thank you, Dr. Parayada, for the kind introduction, but thank you very much to Dr. Weiss and the Department of Medicine for the invitation. So I was asked to give an update on the most hot topic in endocrinology in 2024, and I couldn't think twice because diabesity is the way to go. But they gave me 20 minutes, so please bear with me that I'm going to be giving you a lot of information that impact cardiology, nephrology, general medicine, internal medicine, hospital medicine. So yes, we're going to be talking about diabetes and obesity, the true pandemic of the 21st century. These are my disclosures. So I'm a member of a few guidelines, and my wife sometimes complains that I spend too many nights on these meetings, but it's always a pleasure to work on this. So the first slide that I want to share with the audience today is where we are right now. And this data is not from 2020. This data goes to 2010. So in the horizontal axis, we've seen the trend on the first graph of obesity and define obesity as a BMI cutoff. And as you see, there was a trend, increasing trends in obesity across all sex and men and women throughout the year. So it started in 1980. So by 1990, we already had those spikes, and you can see there the spikes there. Of course, the extreme obese category has been stable because, of course, that one is really not the big percentage of the sample, but the other ones start increasing around 1980. On the other graph, it's very interesting that about 10 years later, we start noticing an increase in diabetes. So you may wonder if they have a relationship, and we know that from the pathophysiology standpoint, there is a relationship between excess adiposity, as I'm going to be mentioning throughout the lecture, also considered by many experts adiposity-based chronic disease, and type 2 diabetes. So excess adiposity, no doubt there is a pathophysiological input on the type 2 diabetes. But what is more interesting is that this is not only an issue in people with type 2 diabetes. This is a study that was published last year from the Johns Hopkins Elizabeth Selbing group. Elizabeth Selbing is the mother of diabetes epidemiology in the country. And then what they are reporting here is the prevalence of overweight, people with overweight and people with obesity that had type 1 and type 2 diabetes and no diabetes. So as you see, what is really, really interesting from this slide is the group with type 1 diabetes. So this is what Dr. Schuyler, our professor of medicine here at the UN, calls type 2 diabetes in people with type 1 diabetes, or type 2 on top of type 1. So if you see 62% of people with type 1 diabetes in the country, this is nationwide data from 2016 to 2020, will have overweight or obesity, in that case, 28%. In type 2, not surprisingly, 82% of them will have overweight or obesity. In other cohorts, maybe in our cohorts here in Miami, this will be higher. But overall, this is the numbers that we manage at national levels. So overall, we have these two conditions. Both of them are considered chronic diseases. Both of them go through the whole pathway of prevention of chronic diseases from primordial, primary, secondary, tertiary prevention, and they both need chronic treatment. One of the biggest limitations in terms of obesity is that obesity was recognized as a disease in 2014 by the AMA. Before that was considered a symptom like headache, pain, or just hair loss. So when you don't have true disease recognition, it's very hard to advance science and treatment for this population. Diabetes has been recognized as a disease for many, many more years. Yes, keep in mind that it's only 10 years ago that we recognized obesity as a disease. So, and we define and diagnose diabetes based on this epidemiological a measure called BMI, body mass index. And it's widely used, is the way we're gonna go for some time, but realistically speaking, it's not the best test. It is really good for epidemiology, it's really good for definition, it's really good for cutoff, but it's not really giving the full picture of the adiposity-based chronic disease. Nice study from my colleagues in University of Navarra in Spain years ago. Basically, what they did was categorize people, about 6,000 patients with BMI less than 18, and they categorized them as, normal BMI. More than 25, they were overweight, and more than 30, they were obese. Or they have obesity. Apology for the terminology. I need to remind myself. And then when they did the body composition study, so-called air displacement plethysmography, what they did was recategorize people that had different BMI categories into excess adiposity. For example, if you have obesity, a BMI more than 30, it was very likely that you will continue to have that based on the body fat content. However, the overweight group, up to 80% of them were recategorized and a category up into obesity because of excess body fat. And normal body mass index people actually had 29% of them were recategorized into obesity. So this is just to illustrate that what we use in clinical medicine sometimes is very helpful, and you can use it to treat population, but from a scientific standpoint, the true disease, the excess adiposity, sometimes goes beyond. And of course, the second study after this was what is the impact of this recategorization, reclassification in dysglycemia. And of course, these people with excess adiposity have a higher risk of having dysglycemia. So just keeping that in mind. We don't have this in clinical practice. I don't even have it in our research program for now. We're working on it. But I think that is very important to understand the limitation for the current diagnostic criteria. So another fact, and I have many slides, but of course 20 minutes is, another fact is our patients don't want to lose weight. That's a fallacy that is sustained and highlighted by the lack of science and the lack of understanding. So if you understand how appetite and energy balance is managed in the body, you need to understand that people do try to lose weight. It's just that it's really hard to maintain that weight loss. This is a publication we had a couple of years with colleagues from UT Southwestern, and it's a so-called obesity protects obesity. So when you, and this is based on studies going on from Priya Sumitran in New England Journal of Medicine 2010. When people are exposed to lifestyle intervention to lose weight, they do lose weight, and the average amount of weight loss, the biggest dip in the weight loss is about first 12 weeks. Around that time, we start having a lot of counter-regulatory hormones. I call them molecular markers in the clinic because patients would like me to measure, and I don't have a way to do it in clinical medicine. We have a lot of counter-regulatory hormones playing a role in here, that such as increase hunger hormones or increase ghrelin and decrease leptin, decrease peptido-YY, decrease CCK, amylin. And those molecular markers increase the hunger and the preference for caloric-dense food preferences, leading to increased energy intake. And then on top of that, there is a decrease in the resting metabolic expenditure, leading to what we call the body fights back. And this is a New York Times article in 2014. I'm gonna need to, is that my email? Hold on, let me just, yeah, it's my email, so apologies for that. How do I do this?
It's okay, Dr. Galindo, we didn't see or hear anything. The presentation
All right.
Fine.
All right. So you see it again?
No, you have to put it up again.
I'm sorry. I'm hearing my email. All right. We're back here. So I was discussing, you hear me now? You see it now?
Yes, thank you.
Excellent. Thank you. So I was discussing these phenomenon of the body fighting back when people go through weight loss interventions, and this occurs about 10, 12 weeks after the process. So yes, there is a fights back to keep energy, and this is based on our genetics. We're supposed to be in the cave hunting and hiding, but our brain have evolved so fast that now we don't do that anymore. So this is the body sensing our weight loss. And there are some studies for Rodolfo from Columbia University, the Naomi Berry Diabetes Center, talking about how many calories this counter-regulatory process will give you if you go through the process. All right, so let's just move on to type 2 diabetes. Well, so what had been happening is a big revolution in the pharmacotherapy, and then back in the 80s, not surprising, New England Journal of Medicine 1975 paper, but Zipperstein and Jesse Roth, the director of diabetes at the NIH at that time, they had a publication saying, maybe the way to treat type 2 diabetes is not by glucose lowering, because we don't have two evidence. And if we actually look at the evidence, we wonder if that is the way to go. They have maybe right at back then. They just didn't have a way to prove it. And then we move into the validation of the A1C that was in the 90s. And of course, Dr. J. Schuyler here was one of the big authors on that, specifically for type 1 diabetes, where we validated A1C as the marker of prevention of diabetes complications. So let's just keep you 1 second here. You got diabetes, you have hyperglycemia. We treat the hyperglycemia, which is the symptom, and then we try to prevent complications, but we're not modifying the disease at all. We're not treating the pathophysiology of the disease. We're treating the symptom. We're not modifying the underlying defect. We're not really modifying the beta cell defect. We're not modifying the insulin resistance. We're just treating the A1C to prevent the complications. A very late process in the treatment of chronic diseases. This is like secondary, tertiary prevention at all. So, but anyways, we use A1C. We were very glucocentric, just focused on A1C reduction for 30 years. And I think that that's what we had. What happened in 2008 is that the FDA said, well, I don't need more medication for A1C reduction. We need something else, because people don't die from high glucoses. They die from cardiovascular disease. And some of these medication may not be safe. And then the sole plethora of cardiovascular outcome trials with thousands of patients and millions of dollars in trials. Some trials require 15,000 patients for 5 years. But anyways, at some point we were complaining that this was too expensive, but now we are really happy that we did it, because not all medications are created equal, and some of them do have a cardiac benefit, a kidney benefit on top of A1C reduction, and some of them don't do that extra cardiorenal benefit. So we move from glucose independent to glucocentric to very prevention of hypoglycemia, because the agents that we had at that time were hypoglycemic agents, and then we were moving into anti-diabetics. I will explain that in a minute. So what happened in 2010, 2015? Well, we were discovering that new agents needed. So this is the very nice graph on how the pharmacotherapy for type 2 have been developed in the United States. And as you see here, metformin was introduced in 1959 outside the United States, but not until the 90s. So the so famous, very good first-line metformin therapy for many years, it didn't really kick off here in the US until 1990. And the problem is that we didn't have anything else that was treating the underlying disease, just lowering glucose, hypoglycemic agents, sulfonylureas, insulin, and of course, metformin, until 2005, the so-called incretin gap. Because now we know that the process of the disease process of type 2 diabetes is not just a beta cell defect. There is also an incretin defect. And that is what the revolution has been. So there is a fallacy that type 2 diabetes is only insulin resistant and beta cell defect. There is also an incretin defect that, in fact, may be actually the best therapeutic target at this time. So the first incretin was in 2005. That came from derived from the Arizona Desert Reserve, where one of the investigators actually at the Bronx VA, he was a faculty at Sinai, discovered this. But there were other people working on this. And this is basically the approval. On top of the graph is approval for type 2 diabetes, and at the bottom is approval for obesity. Many of the incretin medication that have been approved, again, 2005, but exenatide twice a day, and then liraglutide, albiglutide, removed from the market because they didn't have proven cardiovascular benefit. Dulaglutide is still around there. Lixisenatide also removed from the market. This was commercialized by Sanofi. Their cardiovascular outcome didn't prove benefits, so you cannot compete in the market when you have medication that prevent cardiorenal events if you do not have those benefits. And then the saga of the liraglutide, semaglutide, and then tirzepatide, we're going to be talking about that in a second. And also keep in mind that some of these medications had also been approved for children. Yes, we do have a pandemic of people younger than 18 with excess adiposity and type 2 diabetes. Yes, medicine is changing. So how these medications work? Well, interesting, we learned that they do many good things before we actually realize how they work. This is so-called reverse research. So most of the time, out of one basic science investigators do basic science research, then translation, and then clinical. Well, these were big clinical trials that demonstrated A1C reduction, cardiovascular prevention, renal prevention, weight loss, but we didn't know how. And then the studies were done afterwards. And now we know that there is expression of GLP-1 in the brain, in the endothelial blood vessels, in the heart, in the liver, pancreas, the GI tract, and also in fat, and also bone, very, very important. And some of those potential receptor sites may be how this medication not just give you A1C reduction, but also better fat content in the liver, more weight loss, cardiovascular prevention, kidney prevention. About a month ago, the FLOW trial with semaglutide was published showing over 20% of reduction of kidney events. And the SELECT trial, semaglutide in people with obesity, were just presented these days on the American Heart Association, 20% reduction of cardiovascular events, to the point that Medicare now approved the use of semaglutide for cardiovascular prevention in people with obesity. So anyway, so I don't pretend to explain this, but it's very interesting that we have many receptors, and supposedly this is where there is actions, and that's why they have more than just A1C reduction effects. So then we move from glucose independent to glucocentric to cardiorenal metabolic, adiposity, and also, of course, glucose. So I think that this is a more holistic approach to type 2 diabetes, where we're treating the symptoms, hyperglycemia, the pathophysiology, adiposity, and of course, some of the complications, cardiorenal events. Really moving from hypoglycemic agents that just lower your glucose to anti-diabetic agents. And this is not new. I saw the chief of rheumatology joining. This is from rheumatology. We have been using drug-modifying agents for years. In diabetes, we only have hypoglycemic agents. And then the question that I pose to the audience is, if you have a patient with cancer, will you want to treat them to a little bit of cancer or no cancer? And this is something that we need to start changing our paradigm in type 2 diabetes. I will explain in a minute. This is a change in the paradigm. This is Ildiko Limbay from University of Texas Southwestern in Dallas, thinking, proposing that we focus so much on hyperglycemia, which is downstream in the disease process, and we need to start treating more upstream with the excess adiposity to prevent not just type 2 diabetes, but many other comorbidities or complications of excess adiposity. And then a little bit of change on this. The problem is that we don't have the studies yet to say on the guidelines, and I'm a member of this committee. Sometimes you have some idea, but you cannot say do it because you don't have evidence to do so. What is very interesting is this is not the way diabetes has been treated in the country. This is data from our group. We published this a couple of months ago. This is data from 10 years nationwide databases in the United States of people with type 2 diabetes and BMI more than 27. If you have a BMI more than 27 and you have type 2 diabetes, you need to be treated with preferentially weight loss inducing medications and less likely weight inducing medications. So what happened is that 45 to 60% of patients were treated in the country with medications here in red on the top that give weight inducing. So maybe we were treating these people to gain weight and then making the disease process worse because we were hypoglycemic treating these people. And unlikely, down here in green, very unlikely using medication that cause weight loss. So this is basically just going into the details of some of the specific weight-reducing diabetes medications and weight-reducing non-diabetes medications that have been there for years. a good commentary by Ildiko on the same publication saying that we're making progress, but still we need to incorporate more weight loss into diabetes care. I'm going to move a little bit because I think that I'm running late. So how much A1C reduction we need in 2021? Well, this is 1.5% up to Sustain Forte. This is semaglutide 2 milligrams. And then Pioneer is semaglutide oral, and then many other GLP-1s. Well, but the problem is that 1.5 A1C reduction is no longer good enough. We have agents that give you 2%, 2.5% A1C reduction. And how much weight loss you need for prevention of type 2 diabetes? So if you do lifestyle, you get up to 5% in randomized controlled trials, so-called diabetes prevention program. If you actually want to prevent diabetes, you need to lose 10%. If you actually want to induce type 2 diabetes remission, you need 10, 15, 20% of body weight reduction. So far, only achievable with semaglutide 2 or 2.4 or tirzepatide high doses. So keep that in mind. If you need to decide a therapeutic area, maybe you need to see how much weight loss the patient needs to have. Well, how much weight loss is a standard in 2021? Well, before this is up to 2020 with Pioneer semaglutide oral. Well, this is like 7 kilograms, which is like 15 pounds. But what about tirzepatide studies? How much weight loss people lost on the SURPASS program, which is tirzepatide in people with type 2 diabetes? So 12 kilograms. So this is 7 kilograms with semaglutide studies up to 12 kilograms with tirzepatide. What about SURMOUNT-2? This is the tirzepatide study in obesity and type 2 diabetes. Well, similar, 14% on tirzepatide high dose, 14 kilograms, I'm sorry. So what is the benchmark? 10 kilograms, 15 kilograms? Well, this is basically the pipeline of medication for weight loss in people with type 2 diabetes. As you see here, there is less weight loss in people with type 2 diabetes, but still, some of the agents here in green is the retatrutide. This is on phase 3 by Lilly. It gives you 16%, 16.9. If you don't have diabetes, then maybe you lose a little bit more. So how, we don't know. I have an abstract coming up at IDA for this, but we don't know yet why people with type 2 diabetes lose less weight. What about having normal A1C? I said before that the target for diabetes have been treating people with an A1C less than 7%. Let's just give you my background here. Normal A1C is 5.7. From 5.7 to 6.5 is considered prediabetes, but there is evidence that prediabetes increases cardiovascular disease and other diseases, right? Retinopathy and so on. The diagnosis is 6.5, but we have been treating people to less than 7. So what oncology or what neurosurgeon or cardiology in the country would treat the patients to 20% of tumor burden? None of them. They treat people to free disease. We have been treating type 2 diabetes to high normal A1C, but it's not actually high normal. It's above the 6.5. Why? Because the studies to validate this were based on hypoglycemic agent that caused so much hypoglycemia, and it was too risky to bring it down. But on tirzepatide, with no hypoglycemia, we'll present that in a second, we can achieve less than 5.7 in up to 40 to 60% of patients. So you wonder, if your mother or your father had type 2 diabetes, do you want to target 7%, 6.5, or 5.7%, which is considered normal? What about having less than 5.7% with no hypoglycemia, up to 40 to 50% of the tirzepatide studies on the high doses? Yes, one every other patient may achieve normal glycemia without hypoglycemia nowadays. Very expensive medications, not getting into that discussion. We're talking about science here. And I'm going to finish in 2 slides. What are the new triple goals for type 2 diabetes? It's just normal A1C. Maybe we need to have normal A1C less than 5.7. Maybe we need to have 10% weight loss. Maybe we need to have no hypoglycemia. And here we have normal A1C, 5% weight loss and no hypoglycemia. And here we have 15% body weight loss. Yes, up to 15 to 30% of patients will achieve those triple targets nowadays. So I don't want to be in the shoes of any of the CEOs of any of the companies because their benchmarks are really tough nowadays. They need to bring really, really potent and really safe medications if they want to be in the market, because very big competition. Regardless, they have like 20 new molecules on phase 2 or phase 3. Well, but sometimes you need insulin. Well, if you do need insulin, please combine it with GLP-1. This is a study that we published last year. The mean A1C was 10.8. So the standard here is basal bolus, a fallacy. Basal bolus in type 2 diabetes just increase weight and increase hypoglycemia, and compared to basal plus GLP-1, cause the same A1C reduction. So we published this trial last year. Basically, you have somebody with very high A1C, consider using, and maybe now we have other therapeutics, but basal bolus, really hard to do, 4 injections a day, very complicated for patients. So simplified treatment, use medication that counteract the action of insulin and give you some weight loss, and maybe you're treating the underlying pathophysiology. So we have moved from hypoglycemic agents to truly drug-modifying agents and anti-diabetic agents. So keep moving the needle, so it's no longer A1C what is needed. And this is a good review that we published last year in BMJ, showing that we moved from glucose-centric to complication-centric, and now we're targeting the pathophysiology of the disease, trying to decrease the insulin resistance. Keep in mind that it's very hard to have diabetes and lack of equity and lack of access, and we need to work on that. And some priorities depending your treatment target. So precision medicine in type 2 diabetes. Happy to share the slides and many other. So what are the new benchmarks for type 2 diabetes with incretins and A1C reduction of 1, 2, or 3%? You tell me. Is it normal A1C or body weight less than 10, 15, 20%? Is the triple combined normal A1C, no hypoglycemia, and weight loss? And do we actually need to monitor glucose in people that are losing 15% of the body weight with 3% A1C reduction, having no hypoglycemia? Happy to share more, my email, my Twitter. Thank you so much, and I welcome now the next speaker. I'm sorry if I went over a couple of minutes.
Thank you, Dr. Galindo, for that all-encompassing view of where we are today and where we came from. I don't want to take away from the next speakers a lot of time. So anybody that has any questions, please put them in the chat. And I know Rodolfo will be more than happy to respond to them. Thank you. Okay, Nicole.
Okay. So now we have Dr. Eric Greidinger. Dr. Greidinger is an associate professor of medicine and microbiology and immunology at the Miller School of Medicine and staff physician in rheumatology at the Miami VA. He received his medical degree and completed an internal medicine residency at the University of Michigan and went on to complete rheumatology fellowship at Johns Hopkins. Dr. Greidinger joined the University of Miami faculty in 2004 and was chief of the Division of Rheumatology for 10 years, starting in 2009. His research interests include anti-RNP autoimmunity, innate immunity in autoimmune diseases, and the topic for today's talk, Raynaud's phenomenon. Please join me in welcoming Dr. Greidinger to part 2 of the University of Miami Department of Medicine's Grand Rounds.
Thank you very much. Financial disclosures. This is Maurice Raynaud, for whom Raynaud's phenomenon is named. He was the first to report it as his doctoral dissertation in 1862. Raynaud's phenomenon clinically is characterized by color changes in response to cold, typically with multiple vascular beds, bilateral involvement, and often with pale or blue coloration. If there is no dividing line, if there's just a bluish hue, then that's not Raynaud's phenomenon. So cold-induced color changes in the peripheral circulation due to local changes in blood flow. For those who are not fond of eponyms, then I propose cryovasculopathy as potentially an alternative way of referring to this condition. The vasculopathy can be seen on angiography with loss of flow in affected areas and with these sharp dividing lines between affected and unaffected areas. The color changes that one can see include blue changes if there is loss of flow in thermoregulatory vessels, but persistent flow in nutrient vessels. White if there's loss of flow to nutrient vessels. So white is indicating active ischemia. And once there's resolution of flow, there can be reactive hyperemia in areas that have experienced ischemic injury with ischemia reperfusion. In addition to the fingers and toes that are the most commonly involved, like these pale toes here, Other areas that have thermoregulatory effects, including nose, ears, lips, and nipples, have also been reported to be involved. About 10% of the general population has Raynaud's phenomenon. It's been estimated to be up to about 5 times more common in women than in men. And most of this group have benign disease with infrequent progression and uncommon local tissue ischemia in the absence of underlying disease. The overall prevalence of Raynaud's phenomenon has been correlated in the past geographically with areas that have colder mean temperatures. So farther from the equator, the prevalence goes up. Primary Raynaud's phenomenon is the immense dominant kind of Raynaud's phenomenon that's present in the community, in the population. But if you look who actually shows up in a clinic complaining of Raynaud's phenomenon, then there's a group which is about 1% or less of this general primary Raynaud's phenomenon group, which is comprised about equally of patients that have an additional, usually inflammatory rheumatic disease and have much more severe issues with ischemia and often the need for more aggressive pharmacologic measures, and another group of patients who don't necessarily have another diagnosis identifiable, but who behave more like the severe secondary Raynaud's phenomenon than like the bulk of primary Raynaud's phenomenon. So if you hear any studies that talk about comparing primary and secondary Raynaud's phenomenon, take note of whether it's a population-based sample or a clinic-based sample. And if it's a clinic-based sample, be skeptical. Pathogenesis of primary Raynaud's phenomenon is an imbalance of local vasoconstriction and local vasodilators with alpha-2 adrenal receptors and other vasoconstrictors, at times overwhelming the effects of local vasodilators, especially in the presence of increased central sympathetic tone. To manage non-ischemic Raynaud's phenomenon, the most effective thing that one can do is to avoid cold exposure, both in affected areas and in the core body. Areas that are more warm climates or in summer as opposed to winter, there's about a 50% difference in some studies, up to about a 2/3 reduction in the number of Raynaud's episodes. Avoiding sudden warm to cool changes also is important. And cool is not freezing. It's anything that would lead to a vasoconstrictive response. So if you feel like you need to put a sweater on, then that's more than cool enough to potentially provoke this. Peripheral vasodilators have also been validated in placebo-controlled studies as treatments for Raynaud's phenomenon. They're not as good as cold avoidance, but you can get a 1/3 to a 1/2 reduction in the number of episodes. And angiotensin receptor blockers, I tend to prefer because they don't have as many secondary side effects like peripheral edema and worsening of reflux as peripheral acting calcium channel blockers. The phosphodiesterase 5 inhibitors may be even more effective than the other groups, but they're more expensive, and some patients may feel awkward using medicines that have primary indications for erectile dysfunction. There have been studies reporting that fluoxetine and SSRI also has benefit in Raynaud's phenomenon. It's not as effective as these other agents, and it's not clear that it's a class effect. There has been a recent GWAS that also suggests that mirtazapine potentially has effects beneficial versus the relevant alpha-2 adrenal receptors, but that's not yet been experimentally validated. There are several other agents that potentially have roles in reducing the excess imbalance of vasoconstriction versus vasodilation, but in the case of prostaglandins or endothelin inhibitors, their risk to benefit ratio may not be acceptable in non-ischemic disease. And in other settings like estrogen avoidance or statins, we're still waiting for the studies to be done to validate their effectiveness. Of note, all of the drug therapy that we're discussing is off-label. Nothing has an FDA approval for an indication for Raynaud's phenomenon. And it's important also to remember that, as always in physics, flow equals pressure gradient divided by resistance. All of these are things that deal with resistance, but think about pressure gradient. If a patient has atherosclerotic lesions upstream, they will make their Raynaud's phenomenon worse. If they're given negative inotropes for their heart, that will make their Raynaud's phenomenon worse. Secondary Raynaud's phenomenon, or ischemic cryovasculopathy, is much more likely to cause direct damage to tissues. I'll also note that non-white patients have an overrepresentation in Raynaud's phenomenon, even though in banks of photos, you may see fewer of such patients. To identify secondary Raynaud's phenomenon, look for evidence of ischemia, such as digital pits or pallor as opposed to blue attacks. One will also see nail-fold capillary abnormalities. We'll get to that in a second. And atypical onset. Individuals with primary Raynaud's phenomenon will have onset in teens to age 40, onset above age 40, or in the presence of clinical manifestations of an inflammatory rheumatic disease, or with suggestive autoantibodies, should raise concern. This is the surface of the fingernail. This is the skin. This area in between are the nail-fold capillaries. You can see that they're very fine, regular hairpins, one right after another, along the border between the skin and the nail. And if you have conditions that are causing nonspecific vasculopathy, these vessels may get a little enlarged, they may get tortuous, they may get branching. If you go to extreme cases of vasculopathy, like in diffuse cutaneous scleroderma or in Crest syndrome, you'll get massive vessel dilatation and areas of dropout where there should be blood vessels present, but there aren't. So the presence of dilatation plus dropout is pathognomonic for scleroderma and is highly suggestive of the presence of secondary Raynaud's phenomena. Lots of vascular mediators lead to these dysmorphic blood vessels. VEGF is substantially upregulated in scleroderma and in other conditions with ischemic Raynaud's phenomenon, as are others. A number of other things can cause peripheral digital ischemia that should be considered, including atherosclerosis, acute thrombosis, either due to antiphospholipid antibody syndrome or other hypercoagulable states, embolic phenomenon with cholesterol emboli, thrombotic or septic emboli. Vasculitis can lead to digital ischemia and can, in some cases, even be cold sensitive, as in cryoglobulinemia. One can have a hypoperfusion syndrome, like with severe CHF, that may lead to ischemia in all sorts of vascular beds, including the digits, and other forms of vascular injury that include frostbite, vibratory damage, Berger's disease, or ergotism. If one is dealing with acute ischemia, this is a serious problem. Patients should be hospitalized and given warmth, aggressive pain control, typically with narcotic analgesics, vasodilators, similar to those that would be indicated for outpatient use. Recent study looking at administrative data nationwide in the US found that there were 4,000 cases admitted to US hospitals between 2016 and 2020. So about 1,000 cases a year across the US. You won't see this every day, but we will see this, typically estimated several cases per year. This same group looking at the Deaconess Hospital, their own experience found that of patients admitted for Raynaud's phenomenon, about 20% had either proximal atherosclerotic lesion or thrombosis that was identified in patients who also had secondary Raynaud's phenomenon. So when these patients are admitted, do the angiography and consider that there could be other things going on leading to their acute ischemia. Other acute management principles can include improving flow either by prostanoid infusion or by local sympathectomy, surgical release, or local Botox injection. It is not clear whether any anticoagulation, other vasodilators like nitropaste have benefit. They've been often used but not validated. There are some early studies that suggest that local stem cell therapy may have a benefit. If you think about what a ischemic digit looks like from the outside, there'll be a sharp dividing line where it's black above that area. But if a surgeon cuts off everything that's black, it's likely that some tissue which is still alive and still perfused underneath will be lost. So unless there's infection or other compelling reason to debride, it's better to let the lesions dry up and fall off on their own, and patients will be left with more tissue than if the surgeons are overly aggressive. Scleroderma, of course, is a classic disease where ischemic end organ damage can be present, not only with acute areas of necrosis and gangrene, but you can see here in this digit, there's still a fingernail left, but the digital tuft has been lost, and to some extent here as well. So in patients who have secondary Raynaud's phenomenon, it's still true that the vasodilators that work for primary Raynaud's phenomenon work, and they're about equally helpful in secondary Raynaud's phenomenon. But it would be nice if there was more that could also be done. And traditional DMARDs have not been found to be effective for the treatment of secondary Raynaud's phenomenon, although in the trials doing immunoablation and stem cell transplantation, for instance, in Scleroderma, these have been reported to have a substantial impact on reducing the frequency and severity of secondary Raynaud's phenomenon, suggesting that there is a role of the immune system in mediating secondary Raynaud's phenomenon. In Scleroderma, Raynaud's phenomenon is the first symptom in about 90% of cases and is ultimately seen in over 95% of cases. There are other forms of vasculopathy that are also present in patients with Scleroderma, like scleroderma renal crisis and pulmonary hypertension, but these are different in detail. They don't occur early, and they respond differently both to vasodilators and to other potentially disease-modifying therapies. Starting in the late 1990s, it was observed that in patients who have active secondary Raynaud's phenomenon, there is massive amounts of endothelial apoptosis, which is present in their blood vessels. And this is well before the classic onion skinning that can be seen in late scleroderma vasculopathy emerges. And there's actually a bird model that was described at that time as well. Some of our own faculty, including Chunming Dong from cardiology and Pascal Goldschmidt, identified that serum-induced apoptosis occurred in Scleroderma and was associated with Raynaud's phenomenon. And this process was dependent on the inhibition of AKT and the upregulation of the proapoptotic molecule BIM. So we since identified monoclonal antibodies that mediated endothelial apoptosis through AKT sequestration, so inhibited AKT in a BIM-dependent pathway, where if you injected these monoclonal antibodies into these normal healthy mice, then 2 weeks later, the thermoregulatory areas in mice, the ears and tails, would fall off, like with ischemic Raynaud's phenomenon. And we found that we could take patients with secondary Raynaud's phenomenon serum, inject it into mice, and see the same thing. And if we depleted the Raynaud's patient serum of anti-K10 antibodies, it lost the effect. It saved the ears. And that additionally, cold exposure led to worse tissue loss than serum transfer in the absence of cold exposure. And it turns out that endothelial cells express cytokeratin 10 in a cold-inducible way, both at the protein level and with about 20-fold upregulation at the mRNA level. We, with collaboration from the Johns Hopkins Scleroderma Center, looked at a cohort of patients with scleroderma with different autoantibody systems to assess the prevalence of anti-K10 antibodies, and found that across the board in patients with scleroderma, they were identifiable in well over 90% of patients, and they were present both in patients who had CREST syndrome and in patients who had diffuse cutaneous scleroderma, either those who have more lung disease risk or more renal disease risk. So this suggests that anti-K10 antibody-induced apoptosis may be a general mechanism, at least across scleroderma and potentially other subsets of secondary Raynaud's phenomenon, where endothelial apoptosis and cold-induced K10 add the additional potential for impairment in flow in blood vessels, both by eliminating the local vasodilatory effects that are largely present in the endothelium, and potentially having additional effects of the apoptotic debris and local inflammatory response to the antigen antibody recognition at the endothelium that are contributing to these effects. In our cohort of patients with anti-RNP autoimmunity that we follow at the University of Miami, we found 42 patients that we followed over time with secondary Raynaud's phenomenon and anti-K10 antibodies. And in 2 of these patients, we observed that on clinical follow-up, they stopped having clinical active Raynaud's phenomenon spontaneously. In one of those 2 cases, there was concurrent loss of anti-K10 antibodies at the same time that there was loss of clinical Raynaud's phenomenon. And in the other case, although the patient still had anti-K10 antibodies, there appeared to be a change in the targeting of the antibodies such that the antibodies present in this patient no longer induced endothelial apoptosis. So primary Raynaud's phenomenon is usually benign. Worrisome Raynaud's phenomenon, typically secondary Raynaud's phenomenon, can be identified clinically, and a variety of options exist for the management of bothersome Raynaud's phenomenon. If you have a patient who has acute ischemia, you should treat them aggressively, but try to avoid debridement when possible. And evidence suggests that ischemic secondary Raynaud's phenomenon is mediated by autoimmune endothelial cell death. And I'll take questions.
Thank you, Eric. That was really interesting, and I appreciate the latest information on your work with various sera and the autoimmunity that's involved in the Raynaud's phenomenon. But from a practical clinical question, let's say you're presented with a patient who has what appears to be Raynaud's phenomenon without the necrosis. When do you make the distinction between some sort of neuropathy, a peripheral neuropathy, versus a vascular condition?
So if there is a peripheral neuropathy, one typically will not see cold-induced color changes in a symmetrical pattern in upper and lower extremities. So I think that would be the key differentiator between primary Raynaud's phenomenon and another cause of peripheral tingling or numbness. And the episodes would typically be episodic, where if there wasn't cold temperature exposure or increased sympathetic tone, like with anxiety, then the flow and the local sensation would be.
Thank you. Well, I want to thank both our speakers today for very excellent presentations. These vignettes are extremely important and educational. I direct everybody's attention to the chat in order to get the link for the MOC and CME credits, and wish everybody a great day and look forward to seeing you next week. Thank you.